Welcome to Voices in the Work, a continuing education podcast from the Texas Opioid Training Initiative. I'm Dr. Lindsay Loetta, Associate Director of the Pharmacy Addictions Research and Medicine Program and Assistant Professor of Practice at the University of Texas at Austin College of Pharmacy. Voices in the Work is designed to share new ideas and fresh perspectives with health professionals and other members of the workforce about substance use disorder prevention, treatment, and recovery. The first season will highlight innovative training strategies used to teach future health professionals about substance use disorders as part of their health professions curricula. This continuing education activity is supported by the Texas Targeted Opioid Response, a public health initiative operated by the Texas Health and Human Services Commission through federal funding from the Substance Abuse and Mental Health Services Administration. Additional funding information is available with this podcast. The views expressed do not necessarily reflect the official policies of the Department of Health and Human Services, Texas Health and Human Services, or the University of Texas, nor does mention of trade names, commercial practices, or organizations imply endorsement by the U.S. or Texas government. As a reminder to listeners, all episodes offer continuing education credit. Information about continuing education credit is available in the podcast description. Today, we're exploring how simulation can be used to prepare health profession students for interprofessional substance use disorder care, not just in theory, but in real-world, team-based decision-making. Today, we're joined by Dr. Brian Fasolka, a clinical associate professor and assistant dean for pre-licensure nursing at New York University Rory Myers College of Nursing, and practicing emergency nurse, whose work focuses on nursing education, professional mentoring, and workforce development. We're also joined by Dr. Jane Gray, an associate professor of practice and educational psychology in the College of Education at the University of Texas at Austin, where she helps prepare future psychologists and other behavioral health professionals for clinical practice. Brian, Jane, thank you both so much for being here.
Thank you.
Thanks for having us.
Yeah. Help us set the stage. What does simulation-based teaching do for substance use disorder education, that other teaching methods can't?
I can start. I'm a psychologist by training, and I train a lot of future psychologists as well as other health professionals. And I can say in the field of psychology, our learners are pretty underprepared for substance use prevention and treatment. And so any type of hands-on learning is extremely valuable for them. And we receive feedback time and time again from all of our learning activities that students really prefer and benefit a lot from activities that help them practice their skills, whether that's interprofessional communication or direct patient care. So simulation training really helps us to provide training in an area where they really need it, in a format that seems to be pretty beneficial for them.
Yeah. I think it's so important for learners to have that safe space where they can practice, would I say this? Or, oh, that didn't work out. Let me try and, try a different approach before they get to experiential settings. And then certainly before they graduate and go out into clinical practice.
Absolutely.
In nursing, it's really important because depending on the type of program that they're in, usually a nursing student does the same amount of clinical hours, but they may do it over a 1-year period versus over, say, a 2 or 3 year period. But we can't control what they're going to encounter at a real clinical site, especially when we're looking at those high-risk, low-occurrence situations. We can't, ensure that the student's going to experience that when they're at a hospital or they're at a clinic, because they'll only take care of the patients who just happen to come in that day. Mm-hmm. And when you look at those high-risk, low-occurrence situations, if that does occur while a student's there, the clinical site's very reluctant to ever let a student actually participate in that care, given that it's a high-risk situation. Whereas in simulation, we can control exactly what is happening. We can ensure that every student gets the same experience in a simulation. And also we can allow the students the freedom to actively participate in the care And we can safely allow them to make mistakes should they do that without any real consequences to any patients. And a lot of times students can really learn from those experiences, even if they do the wrong thing, because in debriefing, we can go through and say, why was that not the right thing to do? And what was the outcome that occurred with this? And we can really discuss that with the group.
Yeah, absolutely. That standardized model so that all students get the same experience. I can definitely relate. I've been in situations, like when you talk about the debriefing, where learners have done simulations and afterwards, like they know, they're like, oh, like I didn't like that. And then, that's when we as faculty, say like, let's talk about it. What would you do different? So yeah, a ton of reflection
Yes.
that can come out of simulation.
And if you're using standardized patients as the patients in simulation, when the actor comes out of their patient role, they'll also really provide amazing feedback to the students about when you said this, I felt like this, or when you said that, I felt reassured by your care. And students can realize the consequences of the words that they use in that situation, whereas a real patient wouldn't necessarily give that feedback to a student.
Totally. And for listeners who may not know, what is a standardized patient?
So standardized patients are professional actors, and many of them, at least the ones that we work with at NYU, might work with many different universities. A lot of them work at different colleges of pharmacy, college of medicine, schools of nursing, and they will be assigned an acting role, and they'll be prepared by our simulation staff for that specific role. They'll learn their character. They know, this patient's history. They know their social story. They know the way that they're supposed to behave. They even know the responses that they're supposed to have depending upon what the student does or does not do in that situation. And the actors that we worked with are just absolutely phenomenal. Being in the room, you truly feel like you're in a real life healthcare situation with a real patient. Then again, these are professional actors, so they are no longer their own self in that situation. They are now the patient that they are in the role of, and they do not come out of that role until the simulation has ended and we've entered the debriefing period.
Yeah, it makes it feel really real.
And it makes this truly feel realistic.
Yeah. Well, Brian, I want to start with you. If you could talk about the simulation that you were involved with. Tell us, what did learners encounter with that experience?
All right. So the simulation that we developed, it was a large simulation with many students. There were about 50 pharmacy students from an outside university. NYU doesn't have a school of pharmacy, so we were working with an outside university. And the nursing students were undergraduate, baccalaureate students, and they were currently enrolled in their psychiatric mental health nursing course. And there were well over 100 nursing students in the simulation as well. So we were dealing with very large groups, which is another challenge that we faced in the development of this scenario. So the simulation was done in 2 phases. There was phase 1 and phase 2. During phase 1, half of the students were in a large lecture hall watching a simulcast of what was happening in the simulation center, while the other half were actually in the simulation center working in, I think, like 4 different rooms with 4 different standardized patients who were having the same scenario acted out in the room. And in phase 1, it was a patient who was in a motor vehicle collision, had seen their primary care provider, received a prescription for oxycodone, 5 milligrams with acetaminophen, and arrived in the emergency department reporting pain and requesting another prescription for additional pain medications. In that scenario, the learners, the pharmacy students, and the nursing students made recommendations to the provider with the prescriptive authority about what should be done to care for this patient. And depending upon the choices that they made, there were consequences that occurred in the second scenario. In phase 2, then, the students who had active roles in phase 1 were now observers in the large lecture hall, while the students who were the observers the first round came into the sim center. In phase 2, the same patient who also just happened to be a registered nurse, and that was one of the a key aspect of the simulation was that the patient was a registered nurse who did happen to be in a motor vehicle collision. The patient now presents to the emergency department again 6 months later, and the patient had received additional prescriptions from another provider, this time for oxycodone, 10 milligrams, presents to the emergency room out of their medication and exhibiting signs of opioid withdrawal. And now the team had to collaborate in terms of developing a plan of care for a patient who truly has pain, but also has symptoms of opioid withdrawal, and also has had many social consequences in the last 6 months related to this, including loss of employment, financial difficulties, problems at home related to this. And so one of the goals of the learning experience was that we wanted the students to see best practices for prescribing opioids and prevention of opioid misuse. We also wanted the students to learn about opioid surveillance programs that exist, especially the pharmacy students played a big role in that part in terms of we had a simulated surveillance program where they were able to look up and see what prescriptions this person had received, how many they had received them, and then note, how many they currently had or did not have with them. And additionally, we were looking at interprofessional collaboration and teamwork because so many of our students oftentimes just learn in silos, and that's not how we take care of patients. So pharmacy students tend to learn with other pharmacy students, with pharmacy faculty, with pharmacist faculties, I should say. And then, nursing students learn with other nursing students and taught by nurses. So in this situation, they were learning about what the role of each team member was in taking care of someone who was experiencing substance use disorder, and then also was in phase 2 was exhibiting signs of opioid withdrawal.
That's so cool. And I was just talking about this actually yesterday with some colleagues about, prescription monitoring programs, and there was a question of, well, how can we bring that into education before experiential learning. And I said, I was like, hang on, I'm going to talk to someone from NYU and I'll keep you posted. But I think that's a really cool opportunity for learners to have because, that's a big question that even I have friends who work in the field who are already licensed. And I think there's a lot of questions around prescribing for pain, but then a concern for development of a substance use disorder. And so just trying to be mindful, like you said, of prevention. So what a cool experience for learners to have. Well, and Jane, I'm hoping you can tell us about the simulation that you're developing, just still in development, but tell us what is the simulation that learners will be doing with yours?
Yeah, so our simulation is focused on adolescents. And in adolescence, the incidence of opioid use is so low, but we are finding that, especially in recent years, it's become increasingly deadly as in terms of accidental overdose, particularly with fentanyl. And so we wanted to design a simulation that would bring together learners from lots of different health professions. This simulation is particularly focused on interprofessional communication and collaboration. And thanks to funding from HRSA, which is the Health Resources and Services Administration, there's a lot of focus on workforce development, specifically with substance use and specifically with youth. So that was one of the objectives of our grant, was to create this learning activity for the students who are supported by that grant. What we wanted to do within our team, we have an integrated behavioral health scholars team at UT, and we also have the Center for Health Interprofessional Education. And this activity sort of brings together the efforts of those two entities to develop this activity to better prepare students to address substance use in adolescence. This simulation is focused primarily on early detection and prevention. So it's a vignette as far as the focus of the simulation. It's not a standardized patient. The focus is on absorbing this clinical vignette and the students discussing together as a team their thoughts about how to conceptualize the problem and then how to move forward and work with a child and family. It's an older adolescent, so the vignette centers around an adolescent who's 17 years old and in high school, and has had some longstanding issues with anxiety. And so he was given a benzodiazepine first in primary care to address panic attacks that were happening at school. And at that time, the family decided not to pursue further behavioral health treatment. And then this adolescent sort of moves forward and is at a party and is given a benzodiazepine by his friend because his prescription ran out, and has an accidental overdose from fentanyl that was in that medication. And so it's the scenario starts with the students examining chart notes from that adolescent's inpatient stay. And then imagining that he is showing up at an outpatient center that is an integrated behavioral health treatment center. So integrated behavioral health meaning medical and behavioral health working together in a collaborative fashion. And so we expect to have learners from medicine, nursing, pharmacy, social work, psychology, and many more that I'm not thinking of at the moment, to um, just put these students into small groups to first discuss, okay, what would we want to do with this teenager? How do we work with the family? And then the vignette unfolds throughout the simulation with some sort of more complicating features. So, for example, we threw some family dynamics in there with parents not necessarily agreeing about prescription medication to address that child's underlying anxiety issues. And then the risk for continued exposure to accidental overdose throughout the simulation. So in the end, they're also meant to kind of think about their own practice and how they can maybe change their practice moving forward. The main objective of this particular simulation is on interprofessional communication and collaboration. So that's what we're really hoping for students to take away from the activity, that they can come better prepared to just talk to each other, given all of the strengths and training backgrounds that they bring into a team. And it's like, as you mentioned, it's still unfolding. And so we're in I would say, almost final development stages. So we'll definitely be piloting it and then continuing to improve it as we see how the learners are responding to the activity. It's very exciting.
That is
Yeah.
really exciting. And another population that I think is so talked about, there's a lot of questions, about adolescence and risk for an accidental overdose. So just another example of a really great opportunity for learners to engage with.
Absolutely. And speaking from training folks in my field, our learners, especially on the child and adolescent side, are a little afraid to ask their adolescent patients about their substance use, and they feel underprepared. They don't know what they would do if it came up. And so what we're finding is there's just a lot of children are not being asked these questions, even though we have really good frameworks for screening and prevention across settings, primary care, schools, behavioral health, where these conversations can be happening. And what we find is that opioid use in particular is such a low incidence in adolescents, but it, as I mentioned before, can be so deadly, and also starts early. So in Texas, high school students are surveyed about their substance use, and we find that the first exposure to opioids is shockingly low for teenagers, even before the teenage years for a lot of kids. So we want these behavioral health, especially in the behavioral health field, providers to be taking the opportunity to have these conversations with kids and not being afraid to do so.
Yeah, absolutely. And I love all the representation from the different professions that you mentioned. I think both of these are just really great examples of how to get each other talking, because if we don't talk while we're still learners, how can we expect each other to be the most effective communicators, when we're licensed and out in practice?
Absolutely.
Well, Brian and Jane, I know I'm curious. I wonder if the listeners might be curious. Tell us, what was the length of time that the learners were engaging with your simulation?
So with our simulation, it was about a half a day learning experience. As with many simulations, the actual interaction with the standardized patient was one of the shortest components of the simulation. Our students completed pre-work prior to arrival that day, specific to substance use disorders. And then prior to the actual simulation, the students received a pre-briefing in the sim center to orient them to the learning environment. During the interaction with the patient, that lasted just several minutes in length, and then the students would report to a debriefing room where the most significant amount of time was spent debriefing on the learning experience.
Ours is a similar length of time, a half day, 3 hours specifically, and it's virtual. So the entire simulation is on Zoom. And Brian described the structure of the simulation they do at NYU. And I think that structure is so important for a simulation. We have similar um, structure in terms of things moving in sort of shorter bursts. We have our students show up and we'll have them pre-assigned to interprofessional groups. And then rather than doing pre-work, we are going to be doing some short theory bursts to sort of blast them with information throughout the vignette. And the first one will be focused on substance use, and then the second one focused on psychological safety and interprofessional conversations. And then they'll immediately apply that knowledge, knowing that the learners, because it's such an interprofessional simulation, they're coming from so many different health professions, they're going to be at different levels. And to fit all of that into a 3-hour simulation with so many different backgrounds and prior knowledge and substance use, specifically in adolescence, we have to kind of burst these nuggets of information to them, and then similarly at the end of the simulation, they'll be doing a debrief to end the simulation and sort of consolidate everything that they've learned. I will say that I've done a very different format of simulation in the past, and we did try to make it a full day, and that was way too long for our learners. The way we structured it was that the learners were only participating in half of the day actively, but they were expected to also observe the second round, and we found that they just fatigued too much with that length of time. So I think a half-day simulation is a great place to at least start when you're designing a simulation.
Kind of that sweet spot, about a half day.
Mm-hmm.
Well, before we move on, take a moment to reflect in your own setting. Where are there opportunities to utilize simulation to support learning in substance use disorder care? So for both of you, I'm wondering, Brian, if you can tell us, what design choices were more important? And then for you, Jane, what are you prioritizing when it comes to the development of your respective simulations?
The one design choice we had to make in our simulation was really specific to the size of the learning group. So we were working with, several hundred students who had to go through this simulation. And that's why we made that decision to do the simulcast, where only half of the students would actively be participating in each of the phases of the simulation. And that relied on the assumption that students can learn from the observer role.
I would almost feel like if it were me, like the pressure's kind of on, that it's being simulcast to, the rest of my colleagues. So
yeah, and then that also relies on everyone to have that agreement of that this is a safe learning space. That if someone made a mistake and people were watching it, they should not be ridiculed or mocked for making that mistake. That the assumption is that everyone there is there to learn, and everyone there is able to do this, and everyone is going to try their best.
Yeah, everyone's learning together. What about for you, Jane?
Yeah, we are still in the design phase of this simulation. So we've been thinking a lot about this particular issue of late. The first thing I'll say is something that's really important with the design of this simulation is the panel that we put together, of which you are a part, Lindsay. And so we have experts from social work, medicine, pharmacy, and nursing and psychology coming together to put this together, and then we've really depending on the experience and the expertise of everybody that's on the panel to really check out whether the design's going to work, whether it feels realistic, whether it's a good fit for the vast range of learners we're going to have participate in the simulation. Now we are still in development phase, and so the design may change. We'll see how it shapes up and how the first group responds to it. We'll be relying a lot on student feedback. We give them surveys to measure, how much they're learning and how comfortable they are with the interprofessional collaboration, for example, and also just general feedback on the simulation. So we'll be doing that, rapid cycle quality improvement as we go through different iterations of the activity.
I think that's really helpful for learners to hear as you're actively developing, because if someone did want to start a simulation, that's what they would have to be doing. So, yeah, pilot that you mentioned, I would imagine super important as part of your development phase.
Yes, absolutely. I think it's important too, as the designer of these activities, to keep in mind that it's not going to be perfect the first time that we implement it. We have to do our best to be ready, but to essentially expect that there are going to be many changes made after we run through it at least once.
Well, I love that both of you have different examples of simulations. One, Brian, yours with a standardized patient, and Jane, yours with this unfolding vignette. For anyone who's listening or is thinking, oh, I want to start bringing simulation into our substance use disorder teaching, what would be like your one piece of advice for any interested educators?
I think that the first and foremost, it's so important to understand what your learning objectives are. We have spent a lot of time on our panel just discussing what are we trying to achieve with these learners, and we really came to the conclusion that we want to focus on the interprofessional communication and collaboration. And for that type of learning objective, the format of an unfolding vignette and the focus on more team communication is most appropriate. I think it is really vital to just get in touch with what you're trying to achieve with the simulation and allow some time to really refine those. We've had multiple meetings going over their learning objectives and changing wording here and there and getting them in line with interprofessional competencies and how do you use language that makes sense across so many different health professions. And then I'll add another piece of advice, which is just to give time to develop it, knowing that you will be changing it after the first run through, and it really helps to have some support for the folks that are involved in designing the simulation. So whether that's just protected time or funding, we're so grateful and privileged to have funding for this activity from HRSA. That's not going to be the case, of course, for every training program. But I also strongly encourage folks to look for that funding because there's so much emphasis right now on preparing health professionals, preparing health professionals to work in an interprofessional fashion and specifically with substance use disorder. So it's possible that there is funding out there that folks are not aware of.
Yeah. All really good points for someone to consider.
The one recommendation I would have, which is actually several parts to it, is as you mentioned already, early planning. You cannot just design a simulation at the last minute. and then implement that and expect it to be a success. So much of the time spent on simulation is in the planning phase, and really sticking to some evidence-based guidelines. Like we typically use INACSL, which is the International Nursing Association for Clinical Simulation and Learning, and abiding by standards that are set, internationally when designing a simulation is really important to have a successful simulation. When you're looking at interprofessional simulations and working across, faculty and students from different colleges, it also gets more complicated, especially when you talk about logistics. So that's why the planning is really, really vital to have a successful simulation, especially if it involves an interprofessional team. When we work with the medical school, they run on a different academic calendar than the nursing school. In this simulation, we were working with students from an outside university. So again, they were on a different academic calendar. So ensuring that you have the time and the facilities and the resources to implement this is really critical. When looking at teaching students about substance use disorders, it's also really important that the faculty organizing the simulation really stick to best standards in terms of the language that they're using, in terms of setting a good example. There are many clinicians out there who still use a lot of stigmatizing language when it comes to substance use disorders. And if you have faculty facilitating a simulation who are using those terms, we're now going to graduate new professionals who are going to use those same terms. So you really want to ensure that the people facilitating the sim are current on what they're teaching and are setting a really good example to avoid that stigmatization that exists with substance use disorders. Because sometimes healthcare providers are the worst offenders when it comes to using that type of language.
100%. Yeah. And the words that we use matter. It impacts patient care, whether they return to care. And yeah, absolutely. Like the people that are leading this education, the learners are going to absorb what we put out. So absolutely. I love that you bring up language, because that's such I say easy, but habits are, hard for people to change, but that is an easy thing for people to correct and to get right from the get-go, while in training. Where should an educator or program start? What's like the first step if they want to implement simulation in their training?
I think that the best place to start is identifying the need. What is it that learners need? Where are the gaps in their training? I think simulation training works so well when Brian was talking before about how simulation is so great to provide sort of a lab environment for learners before they go into the real world, into patient care. And so identifying what is it that our learners really need before they get into that real world. Substance use is a great example. It's something that all health professions, need more practice with, and really understanding what those, beginning ideas of what your learning objectives are going to be.
I would suggest that the team facilitating the simulation, in addition to what you're mentioning, is also the people facilitating and creating the simulation, they need to be knowledgeable about simulation itself. So many of us have, PhDs and degrees that are research-based, and those programs typically don't teach you how to organize, plan, and implement a simulation. So looking at some of the, as I mentioned, evidence-based guidelines that exist out there about best practices for simulation. So the people developing need to be informed about simulation prior to actually creating a simulation.
Well, I'm also curious, what are some barriers that you all maybe faced that listeners should be aware of? Any challenges?
I think one of the barriers that we experienced with this simulation that ultimately happened is the challenges that the logistics play in terms of maintaining this experience over time.
Mhm.
So we don't currently run this experience anymore. And that's a lot had to do with, inability to keep up with the logistics and the complicated means that had to be in place in order to keep this simulation going in collaboration with another university.
Especially an external
Right.
partner too.
Right.
Yeah. Yeah. I'm glad you say that because, that's the realism behind, putting something like this on when you've got, like I said, 2, external collaborators.
Logistics, definitely
Mhm.
a big barrier. Scheduling, finding not just scheduling in terms of, the time of day, how long it's going to be, but also it's very specifically where in the semester. We have learned from doing interprofessional learning activities of all sorts that we can really run into issues when we schedule something just before, for example, clinical placements are being done and all the students are out interviewing with their potential practicum placements for the next year, or there's a big conference scheduled at the same time, or it's a heavy class day. Um, there are all kinds of things that can pop up, and you really have to get calendars way ahead of time. That's definitely a barrier. And then the other thing that I think comes up is that even with all of the planning and preparation that we do to design these simulations, uh, students are really sensitive to just the smallest glitch that we didn't think of. And so that's why I really recommend thinking of your first run as a pilot, um, because you'll just find out very quickly, like things that were unclear, that the whole panel of experts thought was crystal clear,
Mhm.
but they get stuck, on a missing piece of information or something that doesn't seem quite right or doesn't make sense to them, or the timing is way off. And so, if you don't allow time for and space to make those modifications as you go, and just being tolerant of things not going perfectly the first time.
That's really great, feedback and considerations for people to think about. Thank you. As we close, take a moment to reflect. What is one element of simulation-based learning you could realistically adapt or incorporate into your own teaching to better prepare learners for substance use disorder care? Well, Brian, Jane, I just want to thank you all so much again for coming on and talking about the experience that you all created or are creating for learners. Really appreciate the conversation. So thank you again for being here.
Thank you. It's been a pleasure.
This was a great conversation. Thank you all so much.
Thanks.